Hi, thank you for joining me on this VICE rounds for osteosarcoma and limb amputation. I'm Dr. Megan Mickelson, an assistant professor of soft tissue and oncologic surgery at Iowa State University. First of all, I would really like to thank Dr. Alvarez and the others at University of Florida for initiating this so that everyone can continue to learn through this pandemic. Let's get started and meet our patient. This is Rue Smith. He's an 8-year-old male castrated English pointer that is presenting to us today for an intermittent limping of his right front leg following roughhousing with the other dog in the house. So we'll meet the owner first. This is Jane. She happens to be my mother-in-law that volunteered to be a model owner in this case. And she's very practical, but also really loves her dog. So take a few minutes to either write down on your own or discuss as a group if you're doing this in a live setting, what questions you would really like to ask the client when obtaining your history. The things that I came up with include how often does Rue actually have these episodes of lameness following roughhousing? When did you first notice that this started? And do you feel like it's progressed over time? Are you noticing it at other times other than roughhousing? And have you tried any medications or seen your primary veterinarian about this issue? Does he have any history of lameness prior to this, either in the same limb or any other limb? And do you have other concerns today? Have you traveled with Rue? And is there any other pertinent medical history that we should know about for him? So Jane tells you that the intermittent limping is started following roughhousing about 2 months ago. They don't notice it at any other time of the day. They're not quite sure if it's getting worse, but it does seem consistent every single time, so it's possible it is getting worse. They happen to have Rimadyl for the other dog in the house, so they did start giving it to Rue without consulting a veterinarian a few weeks ago. They gave it for about 2 weeks, didn't notice a difference, and stopped. The last dose was probably sometime last week. There's no other pertinent medical history for Rue. He's not traveled outside of wherever you are, and the owner has no additional concerns at this time. He's eating and drinking normally, urinating and defecating normally, and he doesn't have a history of any orthopedic or neurologic concerns in his past. So now take a few minutes to think about what your focus of your physical exam might be. Of course, any patient coming into the hospital and seeing you is going to get a thorough physical exam, but are there certain areas that you are going to take extra care with in Rue's case? And what do you feel like you see in this image? On physical exam, his TPR is within normal limits. He's of good body condition score and weighs 23 kilograms. You do elicit pain on palpation over the distal right antebrachium, and that firm swelling, that you saw in the picture on the previous slide, is firm on palpation and feels consistent with bone. You can't quite tell on your exam. He is a mild grade 1 out of 5 lameness on his right forelimb when you do a gait exam. You don't find any other neurologic or orthopedic abnormalities, and the remainder of his physical exam is unremarkable. The important parts that you should focus on anytime you're seeing a dog like this with a lameness is really doing a full orthopedic and neurologic examination, especially when it comes to potential treatment options that we'll discuss later with the client. It's important to have performed full examinations on both of these fronts. Now, take a few minutes with the information you've collected on your physical exam and your history to come up with some differential diagnoses for Rue at this time. The things that I came up with include a primary bone tumor. He is an older dog with this palpable firm swelling of the distal antebrachium. And of primary bone tumors, osteosarcoma would be the most common, followed by chondrosarcoma, and certainly other types of sarcomas. Other things that may become more evident after we do diagnostics are things like osteomyelitis, which could be fungal or bacterial. And then we can have firm swellings that are consistent with bone infarcts or cysts. Possibly he also had a chronic malunion fracture or some sort of trauma or incident that went unnoticed that created this swelling. Other things that seem much less likely but possible are things like a soft tissue neoplasm, maybe your other differentials for a mass-like lesion that would include a granuloma or an abscess. And then certainly we mentioned trauma, but maybe he just has a soft tissue injury or swelling. It seems more firm than on exam, but certainly you should include these. And you may have come up with multiple other differentials at this time. So now Jane wants to know what our plan is. So take a few minutes based on this information to come up with a diagnostic plan that you want to present to the client. So first of all, I would recommend blood work. More than likely, we're going to recommend some diagnostics today that are going to include the need for sedation. And if the owner proceeds with treatment, we're likely going to need some sort of anesthesia in the future. He hasn't had any past blood work. He did have NSAIDs without direction from a vet. It'd be important to get a hold of any systemic changes that he might have. For me, this would include at least a CBC in chemistry, oftentimes a urinalysis as well, or at least a USG. And then we're going to want to take radiographs of that firm swelling. And remember, anytime you take radiographs of something, you want orthogonal views. So for us at our institution, we would put this in as a request for radius ulna or forelimb radiograph, and we would get a cranial caudal and at least a lateral. And then it's also important to consider 3-view thoracic radiographs. At this time, cancer is high on our list of differentials for RU, and so we're screening for pulmonary metastasis, but again, we're likely going to be performing anesthesia if we proceed with treatment, and it's important to make sure we don't miss anything as far as heart and lungs are concerned, even though auscultation is unremarkable. Other things on our list, such as fungal osteomyelitis, can cause changes within the lungs themselves as well. So multiple reasons to justify thoracic radiographs. And remember, we're always taking 3 views. And then we want to find out what this is. So the appearance on radiographs may end up helping us quite a bit. However, we can also aspirate the lesion with a needle and obtain cytology to get the client an answer. Other things to think about are potential fungal testing. And we may not need to do this if we get an aspirate that's diagnostic for us, but in our area in the Midwest, things like blastomycosis are high on the list. And so we could consider submitting a blastourine antigen. However, you have to remember that these are send-out tests. So for us, it might be several days before we can get these results and proceed with treatment at that point if the client wants to wait. Other things that we might think about are advanced imaging, mostly to do with staging or where might our suspicious cancer be. And these are things we can touch on a little bit more later. So first of all, let's look at Rue's CBC. So here is his CBC. Overall, it's pretty unremarkable. He does have a mild lymphocytosis or lymphopenia, excuse me, and he doesn't have really any other changes that would be concerning. One of the things that's important to remember if we're talking about osteosarcoma is that a monocytosis can be consistent with a negative prognostic indicator, and oftentimes it actually is within the reference range. So we talk about 0.4 or 400, and his monocyte count on his CBC is technically above that in the literature. This is Rue's chemistry panel, and overall it's pretty unremarkable. A mild hypomagnesemia, but otherwise no concerns here. The other thing we want to focus on for patients where osteosarcoma is on our list of differentials is alkaline phosphatase itself can be a negative prognostic indicator. And that would be if it's elevated above the reference range, but also if it fails to decrease after we have treated the patient. Rue's alk phos is within normal limits on his chemistry. So we obtained these limb radiographs, and we have our cranial caudal on the right and our lateral view on the left. So why don't you take a few minutes to interpret the radiographic findings and decide what you might want to do next. So if we look at the radiographs, what we can see is a very mixed lesion with lysis and periosteal bone reaction. So here we can see of the distal antebrachium on the right, this increase in bone here. And then on the cranial caudal, it's a little more obvious that there's this moth-eaten or lytic appearance. There's also secondary soft tissue swelling over the lesion, but primarily this appears to be a bone lesion. And other things that you might hear people refer to on these would be some of them will have a sunburst appearance, undulating bone margins, cortical destruction, which I think we can argue there's cortical destruction here. You see this nice bright white cortex, and then you sort of lose that appearance distally. And then it's important that you always want to evaluate for a pathologic fracture as well. So here is an example from a different case that presented as an older patient without a history of trauma with a fracture. And if we look closely at that fracture line, we can see this moth-eaten appearance, and that's definitely suspicious for a pathologic fracture in this case. The other things consistent in Rue's case are that this is considered a monostotic lesion, meaning it's isolated to one bone. It doesn't appear to cross the joint or cross over and affect the ulna at all. So the things we might want to do next are things that we've already talked to the client about. We talked about proceeding with thoracic radiographs. So here are your 3-view thoracic radiographs. And most importantly, I don't see any evidence of pulmonary metastasis. I also think all the remaining structures are within normal limits for Rue. And then we've proceeded with an aspirate of the lesion. And in this case, we can use the radiographs along with the gross palpable area to decide where we're going to aspirate. Most commonly, I will try this with a 22 gauge needle, but I have used an 18 gauge, and I typically do this with the patient sedated because it is painful. This is an example of a cytology that is showing mesenchymal cells, and you can see this really ugly multinucleate cell. There are mitotic figures in here, and this is the report that we got from our clinical pathologist. So you can tell that they were able to give us a diagnosis of sarcoma, and they looked at criteria of malignancy. So they looked at those mitotic figures and pleomorphism and mesocytosis, and they also describe the matrix that's present. And something I want to point out is that they've run an alkaline phosphatase stain, which makes this most consistent with an osteosarcoma. But this is pretty typical that a pathologist may just tell you sarcoma rather than a definitive osteosarcoma prior to talking to the client. But this is enough for us to move forward with the client with a great idea of what's happening for this patient. Now, I just wanted to point out for teaching that if you don't get a diagnostic cytology, you can also try an ultrasound guided sample, especially for those lesions that are more challenging to feel grossly, and that can increase your diagnostic likelihood because the radiologist can find a lytic area to kind of sink in and get a good sample. I just wanted to point out other options. If you can't get a diagnosis that way, or you have kind of a strange lesion, then you could do a bone biopsy. Most often, this is going to be with a Jamshidi needle that is pictured on the left. And the technique we use is commonly a closed technique where you make a stab incision in the skin with usually an 11 blade, and then the stylet on the inside is taken out as soon as you reach the cis or near cortex. And then you want to sample in the center of the lesion of bone. Now, it's important to remember that that's different than other lesions where we want to stay towards the periphery so we don't just get necrotic cells. In the bone sample, if you stay only near the periphery, you may just get reactive bone and not a helpful diagnosis. So it's important that you actually stay in the center. And then we will create one hole in the bone and then get multiple samples redirecting at different angles. And depending on how lytic this is, you may have to use quite a bit of pressure on the cortex in a twisting motion to achieve your samples. And these are really nice samples on the right, so they kind of look like little worms. You want a few of those. And if you do have a nebulous lesion, it would be important to also submit a sample for culture and susceptibility. And sometimes, depending on where you are, you have to submit a separate one for fungal, which would be important in these cases. You can also do bone biopsies in an open fashion where you do a small incision surgically and take samples from there. Now, these are radiographs that are showing using the radiographs before biopsy to help guide exactly where you're going to take your sample, but also really important to take them afterwards to confirm that you were in the right spot to get a diagnostic sample and that you didn't create a pathologic fracture. It's important not to penetrate through that transcortex because, of course, that would increase your risk of a path fracture. What I don't like about this is it's definitely an older case, and this individual took biopsies in multiple places. And remember, I would only recommend one hole in the bone and then redirect from there. So technically this would be incorrect. It would increase your risk of fracture. They also used what's called a Michel trephine, which is a much larger needle, which also we don't commonly use anymore because of that reason. They have an increased risk of fracture with bigger holes in the bone. So now take a few minutes to decide how you're going to explain to the client what's causing this in their pet and what treatment options you think are available for Rue. So a clear understanding from the client will definitely help them make an informed decision. So oftentimes when it comes to explaining to a client that their pet has cancer, it's not a fast conversation. So I typically start with explaining what is happening to Rue. So that would entail discussing the type of cancer that he has, and then explaining what that actually means. So going into the staging tests that we recommend and or already performed, and what that might mean for his prognosis. And of course, the most important thing the client wants to know is how long their pet is going to live with something like this. And then we can discuss what our treatment options actually are and what the goals of each of those options entails. If we're moving forward with surgery, in this case, we're going to be discussing amputation and or a limb-sparing surgery option, and it's important to discuss the risks and benefits of those surgeries. And then oftentimes they may want to know what else they can do. So for me, with any cancer patient, this includes discussing palliative care options, as well as our postoperative chemotherapy and or radiation options that we have for them. So first of all, Rue has a malignant tumor or cancer of his bone. And in dogs, the most common type of primary bone tumor we see is osteosarcoma. His fine needle aspirate was consistent with sarcoma, which is a broad category that includes osteosarcoma. It could certainly be a different type, but for the sake of going over this with the client, I'll usually focus on osteosarcoma and let them know the final histopath could change the details of our conversation, but especially in Rue's case with the alkaline phosphatase staining and the actual cytology, it's very consistent with osteosarcoma. And if we remember that osteosarcoma tends to be monostotic or in one single bone and doesn't like to cross joints, it also has a predilection for the metaphyseal region of bones, and that can be proximal or distal. And then you probably learned in school the adage of away from the elbow and towards the knee as the areas that osteosarcoma is most commonly found. And Rue definitely is consistent with that as far as his tumor being in the distal radius being the most common location for dogs. And I oftentimes will show the radiographs to the client as well at this time and explain to them what we're seeing, what that lysis means, and how that's really consistent with the pain and discomfort that Rue is displaying with his limping that they're seeing at home. And then discussing what this means with the client means we emphasize that local disease that we already talked about as the primary tumor and a source of discomfort. And then I talk to them about metastasis or spread of the tumor. In Rue's case, great news, we don't have any evidence of spread to the chest at this time, which this type of tumor likes to spread to the lungs. And then up to about 8% of cases will spread to other bones in the body. On Rue's physical exam, we didn't find any other sources of discomfort or pain that would be consistent with this, and less than 5% of them will spread to lymph nodes. On his physical exam, his lymph nodes were small and within normal limits. For the right forelimb, we would be thinking about the prescapular and the axillary and accessory axillary lymph nodes. And it's important that if those are big, that we try to obtain aspirates, especially if they're large, because that can greatly change the prognosis for the patient. So the other ways that we could further explore metastasis for patients like this, we know that above 90% of them probably have what we consider micrometastasis in the lungs at the time of diagnosis. What that means is that they're too small for us to actually see, but we assume that they're there. And there are some tests that we can do that are more sensitive than chest x-rays, and it's important to talk to clients about that. I will say the vast majority of clients are happy to proceed with the information we've gathered at this point, but certainly there are people that will want more advanced diagnostics, and we need to offer them. So in people, standard of care would be a positron emission tomography or PET-CT, where a molecule is injected of glucose, and we know that cancer and inflammation take up glucose more readily. So that might identify lesions that are worth further exploring that might be consistent with metastasis. Now, a PET-CT is unfortunately not highly available within veterinary medicine, so many of us do not have access to that modality, but certainly can discuss referral for that information. Other things that have been done are things like nuclear scintigraphy or bone scans, like pictured here. This particular patient has a proximal humeral lesion, and then you can see that this area on the sternum and this area on the tail are bright, and that means that they're taking up the radionuclide. And the bladder filters that, so it's naturally going to also appear the same way. Now, these are lesions that are most consistent with metastasis, given that we know this patient has a sarcoma in their proximal humerus, but it's not specific to cancer. So these are lesions that need to be further imaged and evaluated to confirm that they're not just inflammation versus metastasis. The other things we can do are a CT scan of the chest. We know that CT of the lungs has greater detail for smaller nodules. And so just because we don't see them on a radiograph, we assume they have to be at least about 5 millimeters to appear on an X-ray, versus a CT scan may be more sensitive and pick up smaller nodules down to about 2 millimeters. Many clients might proceed with these options. It's still good to have baseline chest x-rays because that's going to be the most common way that we're going to restage this patient down the road is with serial x-rays. So when we talk about treatment options for Rue, this includes both palliative care, meaning that we just want to keep Rue as comfortable as possible for as long as possible, and what we would define as definitive treatment or definitive care. And that's as aggressive as we can possibly be. And when we're talking about osteosarcoma, that includes both local control and systemic chemotherapy because of that high metastatic rate. So we'll talk about local control options in more detail next, but it's important that we mention for the best possible prognosis for Rue, it would include both of these. And I will typically let clients know at this time the median survival time. So if we do everything possible for Rue with definitive treatment, median survival time is about a year. There are a subset of patients that live significantly longer than that. So about 25% are alive at 2 years and 10% alive 3 or more years. Negative prognostic indicators include juvenile patients, which Rue is not. Remember, this is a bimodal disease, so we can see, unfortunately, juvenile dogs and older dogs. And then proximal humerus has been noted to be potentially a worse prognosis, along with those blood markers that we talked about. If there were lymph node metastasis, it's important for us to know that information because those pets have a median survival time closer to a month. And certainly if there are pulmonary metastasis, we tend to think about weeks to months at most. If we're pursuing palliative care, it depends on the option, but if we're doing palliative care with medications alone, we tend to think weeks to months, depending on the individual patient, for how long we can keep them comfortable. As far as our local options go for RU, the standard of care is still considered limb amputation. And this is something that you want to ease into the conversation with the client about. It takes a lot of conversation. Most people have a negative connotation about amputation before we've talked to them. Other options for RU would include limb-sparing surgery, which there are many different types, or stereotactic radiation therapy, which was pictured on this slide. Now, most of the time, we are recommending amputation and discussing the other options for patients. And the reason to choose other options might be owner preference, or if we feel the patient has a contraindication for limb amputation. So now take a few minutes to discuss as a group, or write some things down if you're doing this individually about what potential contraindications exist for limb amputation in our patients. We tend to think about this in multiple categories. So it's not fair to say that one of these alone is necessarily a contraindication, but something that might make you talk to the client more. Neurologic disease alone is probably one of those that could be a strong contraindication, especially those patients that have a reason to have underlying ataxia, anything that really alters their balance. You obviously wouldn't want to make them a tripod where they might have more difficulty. Things like historical intervertebral disc disease are not uncommon in older pets, and that may increase their risk. So it's important to talk to clients, but if they currently don't have any pain on palpation or any clinical signs or neurologic deficits, it's not something that would prohibit moving forward. It's also really common in our older pets that they have underlying osteoarthritis of some or multiple joints, and that alone is not a contraindication to amputation. There are certainly patients that are much more severe that wouldn't tolerate amputation as well, and it is something to discuss with the client. These also might be patients that would benefit even postoperatively from continued medications and or rehabilitation. And then a common misconception is that breed or size is a contraindication. So a patient like this, or a Great Dane, something like that, that is a giant breed dog can still tolerate a limb amputation. It certainly is something worth the client thinking about as far as TLC at home, and individually carrying this patient up and down the stairs may not be an option versus if they have a Yorkie. So it may take a little extra care at home for them as the patient is adapting at the beginning, but they can certainly tolerate it well despite their size. Now, things like morbid obesity could actually be a contraindication. Certainly those pets have more weight on their joints, and if we place them on 3 legs, they may be unwilling or unable to adapt on 3 legs. Something that definitely needs to be emphasized with the client at that time. And then things like owner preference are really important. You're going to have clients, regardless of how you explain it and what you say, that refuse to do limb amputation for whatever reason. And so that's why it is important to consider our other treatment modalities. So as far as surgery goes, again, in this case, a 4-quarter amputation would be considered standard of care. But other things that I talk about are limb-sparing surgery. The distal radius happens to be an excellent location for a limb spare surgery. This is just one of those many types that's pictured here, where essentially with these types of surgery, the tumor itself is removed and then replaced with something. So here we're replacing with a bone allograft and a plate that essentially creates an arthrodesis. There are endoprostheses that are probably the most common, where there's some sort of metal that attaches to the plate to bridge that gap. And of course, anytime we're using implants, we also have the risk of implant failure and infection. And the risks of limb sparing surgery can be quite high. So it takes a special owner and a special patient for this to be possible. And of course, this is a referral surgery to a boarded surgeon. Infection rates, depending on what type of procedure is performed, can range all the way up to 85%. And that can be mild, just needing a course of antibiotics, to severe with implant infection. And this patient relies on the implant, unlike a healed fracture or a TPLO, where you could remove the implant later once the bone is healed. These patients need that implant lifelong. So this could mean severity up to the point of needing a limb amputation with complications. And then we have things like partial limb amputation with prostheses, such as the orthopets pictured here. This is also something that should be referred to a boarded diplomat, because it's important that we work with a rehab specialist and a prosthetician, because proper fit of the prosthesis is one of the most important measures of the outcome. And even still, this is really early in its development within veterinary medicine, and some people are having pretty good outcomes here. So something that we hopefully will see improvement in the coming years within our field. Now, you've talked through all of this with Jane, and she's a bit overwhelmed, but she asks you, well, you know, I want to help Rue, but what if I do nothing? Chemotherapy sounds really scary. First of all, we should definitely address her concerns regarding chemotherapy. What I tell clients is that, unfortunately, many of us have personal experience with family members or friends at this point that have gone through chemotherapy, and it's quite different in dogs and cats. Overall, it's much better tolerated. Up to about 25% of our pets will experience side effects from chemotherapy. Most commonly, those are going to be things like GI signs, and we will send home medications for that, anti-nausea medications, antidiarrheals. So the vast majority of these can be managed well at home. However, if signs occur, we want to know about that, because we may need to adjust the dose or change the chemotherapeutic or even stop. When you start chemotherapy, you're not signing a contract. So it doesn't mean that you have to complete the protocol if you're not happy with how Rue is doing and how things are going. The other thing we always monitor closely are their cell counts, because it can affect those cells that fight infection, those white blood cells. And so we need to make sure cell counts stay good. So throughout the protocol, blood work is checked regularly to make sure Rue is healthy and doesn't need any antibiotics. Up to about 5% of patients might need some sort of supportive care in the hospital. Maybe they need fluids or IV antibiotics for a few days. And less than 1% of them can experience severe side effects, including death from chemotherapy. This is certainly something to think about, and you don't have to make that decision today. You asked about other options, so I think we should talk about what palliative care would entail in more detail. Ultimately, that includes a lot of oral medications at home, but we also have the option of doing injectable medications such as bisphosphonates, which are osteoclast inhibitors, meaning that they stop the bone from breaking down. There are also radiation options. Instead of that stereotactic radiotherapy, that's a definitive treatment to really kill all of those tumor cells, we can do palliative radiation, which can help ease the pain in up to 85% of cases. And the amount of time that lasts is variable by the patient, but these protocols can be repeated down the road if it does help Rue. Surgery in and of itself, even without chemotherapy, is palliative, because we're removing that source of discomfort for Rue. So he may benefit just from surgery alone, even if you decide not to pursue chemotherapy. Now, with any of these techniques, we obviously aren't aiming for that median survival time of a year, and so we expect less time for Rue in the long run if we're not including chemotherapy in his plan, but certainly a valid option. The other thing that it's important to bring up to the client at this time is that it's okay to be considering euthanasia. I don't think we're there for Rue right now, because he's not on any medications. We have a lot of room to improve his quality of life. If we choose to just do medications for him at home, I would want to make sure we're still monitoring him closely. If at any time he becomes non-weight-bearing lame, it would be an emergency to have him evaluated because we can see fractures develop because of the weakened bone, and we would want to make sure that's not going on for him because that's not a fracture that can be repaired. But also considering how his pain is controlled and his quality of life. For those palliative care medications, the things that I think about for these pets are usually some sort of cocktail of multiple drugs. Rue's not on anything, so we have a clean slate to start a couple things. Most of the time, his blood work is normal. Most of the time, our patients can tolerate a non-steroidal anti-inflammatory, so I would typically be starting that, as long as they're healthy and eating well. And then gabapentin is a great drug for this, as well as tramadol. Tramadol alone is not typically very helpful, but coupled with other medications can be really beneficial in these patients. Other things that could be added in addition to this would be things like acetaminophen, with or without codeine. It's well tolerated in dogs, cannot be given to cats. This is a drug, of course, with the codeine, it's going to be controlled like tramadol. Acetaminophen can be given at the same time as an NSAID, like carprofen. I would just make sure the client knows to not give either of those if the pet's not eating, and make sure as long as they're feeling well, eating and drinking, it should be okay. And then amantadine is also a great drug. It was initially just used for refractory neuropathic pain, but it has really helped a lot of amputation patients and dogs with bone tumors that do not undergo surgery. The range for amantadine can be a lot higher than this, but I'll typically start at a lower dose twice a day and then go from there. The downside of amantadine is that it can be kind of expensive for those large and giant breed dogs. And then again, we could incorporate bisphosphonates like we mentioned on the slide before. They're not true chemotherapeutics, but they're definitely administered as such. So they're given as an IV infusion every 4 to 6 weeks. So Jane has decided she wants us to do surgery. She just isn't quite sure about chemotherapy yet. Great, we can absolutely discuss that more when we get the final histopath back, and you don't have to decide that today. So our treatment goal for Rue with limb amputation is to remove that source of pain, and we're actually removing his gross tumor at the same time. Our approach is going to be a 4-quarter amputation. So when we do this surgery, we position these patients in lateral recumbency with a hanging limb, like pictured here. The other thing that's important to mention is that we quadruple check that this is the correct limb. If it was a human and we were going in for an orthopedic surgery, they might have us sign our leg or arm to confirm we're doing the correct appendage. So in our patients, multiple people do this in different ways, but you could shave a spot in front of the client to confirm the correct limb. Some people will paint toenails. Of course, with Rue, he has a big gross tumor that we can palpate and see. So for him, it's probably less important because it'll be obvious that we have the correct limb. If you're doing an amputation for a soft tissue tumor, it may be obvious because you see the tumor as well. Something that I will additionally do is have multiple people double check the radiographs that I have the correct limb, the correct radiograph, etc. Here you can see with a sterile marking pen, the most common incision for a 4-quarter amputation is marked. Most people track up the spine of the scapula and then around the proximal brachium or proximal humerus. If you have a proximal humeral tumor located here, you want to adjust this incision to accommodate for margins around that tumor. It also means you're going to take more of certain muscles like the pectorals to ensure that you keep a margin around that tumor. And always have enough skin to close. So the worst case scenario is that you take too much skin at the beginning. The best case scenario is you can resect some of this skin at a later date. So when you're performing an amputation, it's important to know all of the muscles that you have to transect. Most people will start on the lateral aspect and go through skin, making sure that you don't create too thin of skin in these patients that could cause ischemia later. And when we transect the muscles, we're going to be transecting trapezius, omotransversaris, and then we're going to be putting something on the kind of spine of the scapula. Oftentimes I'll use a towel clamp and have the assistant retract while we go for rhomboideus and serratus ventralis. And the vast majority of people like to approach the brachial plexus from that angle with the scapula retracted laterally, but you can certainly approach it essentially ventrally as well. And once we're at the brachial plexus, we will very cautiously dissect the nerves and blood vessels. When we are going to transect nerves, we will inject the perineurin with either bupivacaine or nocita, which is a long-lasting liposomal bupivacaine, prior to transecting. For vessels, remember your principles of a large vessel. And that includes that adage of 2 to stay, 1 to go away. So basically 2 ligatures are going to stay with your patient. I will do an encircling ligature and then a transfixation ligature on the part that stays with my patient. You can speed this up by using things like hemoclips or clamps on the side that goes away. You can also use the ligature, which is a device that cauterizes and cuts and is labeled for up to 7mm vessels. My preference is to have a suture ligation on the vessel because if they retract away from me, they will retract into the chest on a 4-limb amputation, and it may be too late to access that to stop the bleeding. As far as doing an amputation for cancer patients, you want to also remove or extirpate the lymph nodes. In a 4-quarter amputation, this entails the axillary and the prescapular lymph nodes. Most of the time, when you're at this level, you'll see the axillary lymph node somewhere on the kind of medial aspect of the limb. And I will typically remove that and submit the lymph nodes separately to ensure that the pathologist looks at them for staging. Once you have the vessels ligated and the nerves injected, you have remaining muscles to remove. So you have the deep pectorals, the brachiocephalicus if you have not, superficial pectorals, and the remaining latissimus dorsi. Now, the other techniques you probably have heard of are mid-humeral amputations, and that's not something that we preferably do, only because that leaves an appendage where all of those muscles being unutilized later will have disuse atrophy, and you will have basically the bone sticking out. Same with leaving the scapula. Eventually those muscles are going to atrophy and you might have bony prominences of the scapula. You will have clients that ask about that and being worried about kind of a flat chest, but in general, that's actually preferred for these patients. A mid-humeral amputation is also more challenging because you have to transect the bone itself, versus this technique, we're actually just transecting muscles to remove the entire limb. So now take a minute. We've touched on a few of them at this point, but think about what risks of surgery that you need to tell Jane about prior to her confirming moving forward. So the things that I came up with are hemorrhage. So we need to be very cautious when we ligate those vessels, but large bleeding is uncommon. Certainly in cats and small dogs, they can't afford to lose as much blood. So it's important that you have cautery techniques available to you for muscle bleeding and things like that as well. Just like any surgery, this is a clean surgery, but the risk of infection and dehiscence or suture failure are there. And this is a big dead space after we remove the limb. So adhering to Halstead's principles with good closure techniques is important, but seroma formation is common and it will pull with gravity when these dogs are standing up. So it's important to note that to a client. Neuroma formation can occur at the end of transected nerves where they get a focal area of inflammation, which leads to pain and discomfort. This is why we always inject our nerves when we transect them. And something that some clients may ask about is phantom limb pain. It is something that I think we need to keep in mind, but definitely not common in our pets. I've only seen a handful of cases in my career that I've been worried this could be happening for those patients, but majority of them will improve with longer term medications and potentially rehab or use of a TENS unit to ease discomfort. The other thing to point out that we talked about initially is their inability to adapt to 3 limbs or difficulty with adaptation. Certainly your patients that are grade 5 lame or non-weight bearing lame are already showing you that they can adapt to that. And those patients typically rebound very quickly and are much happier just to have the discomfort of the tumor gone. But patients like Rue that are still using the leg the vast majority of the time, only grade 1 lame, may take a little bit more time to get used to it and adapt. And then incomplete tumor resection is something that we should always talk about anytime we're dealing with cancer. However, in a distal radial tumor like Rue's, this is not something on the list. If we are talking about a limb spare surgery, this is absolutely something we think about, along with the potential for tumor recurrence in the area up to about 30% of the time. And then certainly we should always mention anesthetic concerns. Rue is otherwise systemically healthy. He has no comorbidities, so I don't have any concerns about him proceeding with anesthesia, but certainly that's always on our form for clients to sign. So now Jane wants to know, how much is this limb amputation going to cost, plus all the staging we've done. So I created something from our hospital infrastructure, could be very different from yours. This is our estimate. Important to include a range. Most of these pets are only going to stay 1 to 2 days in the hospital, as long as they're doing well, but I like to account for if there's a complication and things like that. So Jane has approved surgery, and Rue's pre-med and anesthetic plan are listed here. So he's otherwise healthy, so there are a lot of options you can come up with here, but he was pre-medded with Dexmed and methadone. An IV catheter was placed, and at our hospital, we administer Cerenia to all anesthesia patients. We try to do that 12 to 24 hours beforehand. So he had Cerenia the night before. And then he was induced with alfaxalone and intubated smoothly. He was maintained on isoflurane at the lowest possible concentration. And we typically request atracurium blocks on our amputations. The reason for that is to block the muscles so there's less twitching. It does tend to speed up the process, and it's easier. It's absolutely not a requirement and not something that's safe to do if you don't have adequate monitoring. It is a clean surgery, as we discussed, so we're going to give cefazolin, 22 to 30 mg per kg, 30 minutes before we cut and every 90 minutes perioperatively. Unless we have any concerns, there's no reason to continue antibiotics routinely in these surgeries afterwards. And then I mentioned the nerve blocks that we do prior to nerve transection, but we are using Nocita in our hospital for amputations to infiltrate the muscles as well before closure. So we can dilute this up to 1 to 5 with sterile saline. Some people will dilute with bupivacaine. The dose is 5.3 mg per kg of Nocita. And this seems to be kind of a game changer as far as postoperative care for them. The main downside at this point of Nocita is that it is expensive, and it's important to know that at this point, majority of the uses for it are off-label. So Rue does great during anesthesia and surgery, and recovery so far has been smooth. Take a few minutes to decide what your postoperative plan might be for him. So here we don't have a true intermediate care, but certainly Rue was stable and did well with everything. He could absolutely recover in intermediate care. And if you don't have that, then he'll probably recover in your ICU. What I would do for him, since he's otherwise stable, is an exam / TPR every 6 hours. And then he got Nocita and did really well, so I'm going to pain score him and then administer an opioid IV every 4 to 6 hours. Since anesthesia chose to use methadone, I would probably continue with methadone. Certainly things like hydromorphone are great as well. He'll be on maintenance IV fluids with IV catheter care, and as soon as he's alert and ready, he can get gabapentin by mouth, and if he's eating, he can get carprofen as well. We could also do an injection of carprofen for 12 to 24 hours before he's eating, since he didn't have any hypotension under anesthesia. And as soon as he's ready, we're going to try to walk him outside and use a sling for support under his chest as needed so he doesn't fall. And early on, he may need to be carted outside and just given a few minutes, or maybe his first walk only entails going to the scale and back, because we want to ease into that. Any patient that has an amputation is going to need a t-shirt or e-collar. It's a misconception that they can't reach the ventral aspect of their incision, but they absolutely can. And we don't want to delay chemotherapy for these patients if they do develop an infection. So it's really important that we do the absolute best to prevent that from happening. I really like to use a t-shirt for forelimb amputations so that they aren't worried about banging into things with the e-collar while they're adapting, but certainly hind limb amputations need an e-collar. Some people will place a compression wrap, either a soft padded bandage or a stockinette, postoperatively while their patients are in the hospital. I kind of went away from doing this because I felt like all it did was delay the seroma formation to when the pet went home, and I really like to be able to ice the incision right away. So I will cover the incision with whatever we have. So those bandages such as opsites, bioguards, primopores, etc., and keep them covered in the hospital. And then ice the incision for 10 to 15 minutes every 6 to 8 hours. And most of these dogs are doing really well and can go home the next day. The vast majority of my patients with no CETA on board are able to get up and try walking the same day as surgery. So this is Rue postoperatively. He's super happy and had an uneventful recovery, and he's about to go home. So the client thanks you, but wants to know basically what are their discharge instructions. So take a few minutes to come up with your at-home care plan for Rue. So when we go over things with the clients, the first thing I'll talk about is exercise restriction for these patients. Most of our pets feel really good when they go home, versus a human with this type of surgery would be probably on the couch for several weeks. But our dogs and cats are pretty amazing. So the biggest part for the client is restricting them. There should be no rough housing or rough play, no running, jumping, climbing on and off furniture or stairs for at least the first 2 weeks. I tend to describe the first 2 weeks as basically jail time, in and out to go potty on a leash, sling support for our amputees if needed. And when they're not home, they should be kenneled or in a small room without furniture and stair access with good grip floors so they aren't slipping. Yoga mats are a really great idea to tell clients about too. If they have hardwoods or tile at home, they can line with yoga mats or rugs. And then a lot of clients, to avoid stairs in these giant breeds, will build ramps or buy them. If they have a way to avoid stairs, that's the best thing to do. And then I tend to talk about gradual increase of activity after that. So once we see the pet for the 2-week recheck, then we can talk about easing them back into regular activity. There's no reason down the road that Rue can't return to agility or playing fetch and running, whatever he loves to do, but we need to ease back into that. Similar to if we stop going to the gym and then we restart again, we need to build back up to being an athlete. We're also going to talk about incision monitoring and care. It's really important that the client looks at the incision at least once a day and then notifies us if they have concerns for redness, swelling, discharge, odor, anything that's concerning. They can email us a picture or call us or their primary veterinarian to be seen. And I will instruct them to ice the incision 2 to 3 times a day for 2 to 3 days, about 10 to 15 minutes at a time, and then switch to warm packing if and when that seroma develops. And the best part about getting rid of a seroma is keeping them quiet and warm packing that. And then we'll go over medications that the pet is going home on. Most of the time for me, that's going to be carprofen and gabapentin, plus or minus tramadol. And then we also will send home trazodone if they need it for an anti-anxiety medication or sedation purposes. Rue's a pretty nutty dog. He likes to bark at the mailman and chase squirrels, and the owner has requested some trazodone to try to take the edge off for the first 2 weeks while he's healing. Important to note, if you're doing tramadol and trazodone, to think about and discuss serotonin syndrome with the client and stick to lower ends of the dose range. Some people will never use the 2 drugs together. Again, Rue should always have a t-shirt or a collar on. This is not a reason not to look at the incision. Remember, the client still needs to be doing that. And then we're going to recommend that recheck for suture removal and incision evaluation in 10 to 14 days, plus or minus starting chemotherapy if that's what the client decides. In the meantime, we're going to call them with that histopath report when it becomes available. But any histopathology involving bone takes decalcification, which can add some time to that. So it's important the client knows that. And then I always emphasize to every client weight management moving forward. Rue is a great body condition score right now, so let's keep it that way so that he doesn't struggle as a tripod. So this is a different patient with a hind limb amputation, but this is our 2-week recheck. At 2 weeks, Rue also looked great. His incision was healed and his sutures were removed. And the client had decided to talk to Oncology about pursuing chemotherapy. So at this time, he's not uncomfortable. He doesn't really need any of those medications anymore. A pet that has underlying osteoarthritis, though, or other conditions might need to stay on some of those medications longer or even lifelong. Prior to initiating chemotherapy, they're going to talk in more detail about that and then perform a CBC to make sure his white blood cells are adequate to receive chemotherapy. And then the most common protocols for osteosarcoma dogs are either carboplatin or doxorubicin, and the protocols definitely vary by the individual oncologist you're working with. And then throughout that, we're going to restage Rue. Most often this includes repeating chest x-rays every 2 to 3 months throughout this protocol and beyond that. This is a different patient that was leaving Teak with a hind limb amputation down the hallway with his little sling support. Super happy tripod. So thank you so much for joining me for this case rounds. If you have any questions, please feel free to comment on this video. And if you are an instructor and would like to contribute, the email is below. Thank you for all the resources.